You've heard it from Nicole, and my talk will not be too much fact-based. So you will not see so many citations and nice graphs and stuff like that. But the bottom line is that for more than 50 years, we had only 5 drugs. So all we could do is put things in a blender, and nothing really important came out. I was complaining 2 days ago that we could come here and spend almost 5 days in a meeting on CLL. It was quite different when I attended my first IW-CLL meeting. It was 2 days. But then the person I was complaining to, she said, yeah, but you only had chlorambucil. And she was right. Can you move forward, please? And as Nicole explained, today we have so many more options, and we are experiencing this drastic change in the overall treatment strategy that we are faced with a big challenge. The challenge is which medicine, which combination of drugs, to which patient, and at the end of the day, what we are talking about means which diagnostics do we need. It's the only, or one of the very few, factual things you will hear from me today, or you will see on my slides. This is what these wise ladies and gentlemen of the IW-CLL committee proposed last year. And this is what we should always do in both general practice and clinical trials, so it's more or less standard. By the way, you are absolutely free to do whatever you want and take pictures, but I'm sure that you can always get the slides after the presentation, so it's the slides will be free. Now, you've heard it also from Nicole. There are some considerations. Age and physical status, it's obvious. This should be obvious, but it's not obvious for every treating physician. So we should hear more about what you want. But in order to do that, we should better inform you about what you can expect and what you might experience. We had a very nice discussion with the client community earlier this morning about how to get more information about patient preferences and what we can do with you. But that's what you invited us to this meeting. You invited me to this meeting. Biological background, in other words, what is happening in these tumor cells is very important about treatment selection. And the wise ladies and gentlemen tell us 2 things. That we always have to test for these aberrations by FISH, this technique. These are chromosomal aberrations, and we have to test them by this technique, fluorescent in situ hybridization, FISH. And we have to do it in any setting. But is it enough? No, it's not enough, because we may miss, if we use FISH only, we may miss some microscopic lesions, some microscopic defects that we call mutations. Just a single change in one letter of the DNA in this gene, a TP53 mutation, may render the protein encoded by this gene very dysfunctional. And the final thing they tell us to test is the status of the immunoglobulin genes. This was quite different until about a year or so. So they were telling us to do all of that, but this is a big change. And thanks, Brian. You are right in that for the last 25 years or so, I've been struggling, along with other people in the ERIC community, to make it a standardized test. So is everything settled? What do you think? Yes or no? I can't agree with you more. that was 2015, so 4 years ago to the day. And this lady, she was 63 at that time. She presented with anemia, so she was not feeling well, and she had some swollen glands. We found that she had lymphocytosis. We ran a flow cytometry test, as Nicole mentioned, and then we had a clear diagnosis of CLL, no doubt about it. Typical CLL, the clinical staging told us that she was Binet stage C. So very advanced disease, even from diagnosis. What do we have to do? You've heard it from Nicole, and you also saw it on the guidelines. So we did FISH, and we found this thing. The report said monoallelic deletion of 13q. In other words, something happening on chromosome 13. This by itself is considered as favorable prognostic. We also analyzed for TP53 mutations, and we used a technique called Sanger sequencing, which is very standard, a very classic methodology for analyzing the DNA. And it was negative for mutations. And we also analyzed the immunoglobulin genes, and they were unmutated. Back at that time, this profile, negative for TP53 aberrations by FISH and by Sanger sequencing for the gene, meant that she was a good candidate. She was considered a good candidate for FCR. It's 4 years ago, not ages ago. So she received FCR and she attained a partial response, but then unfortunately, she progressed fast and she was again in need of treatment. This profile is what we call ultra-high-risk CLL. And not ages ago, but only 4 years ago, in some countries, in most countries in the world, this would have been really horrible. Now, what do the recommendations tell us? They tell us to repeat testing. So we did that. You don't have to repeat for immunoglobulin genes. You've heard it from Nicole. They do not change. But genomic aberrations, lesions in the DNA, may change. So we did FISH, but it was exactly the same. We tested for TP53 mutations, but this time we used a different methodology for analyzing the DNA. It's called next generation sequencing, NGS. And the difference from Sanger, I will not go into details. What is relevant for today's discussion is that NGS is far more sensitive than Sanger. If you run Sanger sequencing and you have a mutation, in order to detect it, it has to be present in 15 to 20% of the entire population. In other words, the sensitivity cutoff of Sanger sequencing is around 15%, meaning that if you have something below 15%, you may miss it. So we did NGS, and we found a pathogenic variant, that's how we call it by NGS, a mutation, in simpler words, at a frequency of 33%. So 1 in 3 cells, 1 in 3 CLL cells carried a pathogenic mutation. We did the obvious. We went back to the sample before frontline treatment. And we found the exact same mutation at a frequency of only 6%. So the mutation was there, but it was below the detection limit of Sanger sequencing. Can you move forward, please? Because it's stuck. Oops. One back. One back. Okay. So, I'll ask you 3 questions. Sanger sequencing or NGS? What do you think? You want NGS? Okay. Do low-frequent mutations matter? Yes or no?
Yes.
Is there a relevant cutoff for positivity? Should we say 1%, 5%, 6%? Yes or no? You say no, Leah? You don't know.
No, but there must be some sort of criteria.
Okay. Let's take it one by one. Sanger or NGS? In an ideal world, I would say NGS, provided you know how to do it. In the real world, we are doing Sanger sequencing in most parts of the world. We are doing it very badly, and it's very expensive. So NGS, a big yes, with appropriate training and appropriate pressure to the payers, who have to understand that in the end, it's much cheaper than Sanger. Question number 2, do low-frequent variants matter? The answer is yes. But when you go to very, very low, you have to be sure that what you're detecting is true rather than, an artifactual thing. So you need reliable testing. And number 3, is there a relevant cutoff? So let's go to and have a look at what we say. So last year we published, Eric published recommendations about that. And what we say here is that there is plenty of evidence that minor clones are clinically relevant. We may discuss later as to why. Now, we were really, conservative, and we said that since Sanger sequencing is the gold standard, because most of the data, the vast majority of data about how bad TP53 is, comes from Sanger sequencing studies, from both the academia and the industry. And as the cutoff in Sanger, the sensitivity is 10 to 15%, we should not, be very bold, and we adopted this conservative 10% cutoff. But then we messed up. Since the 10% cutoff is arbitrary, variants with 5 to 10 can also be reported, and this and that and the other. Sorry guys, but this is nonsense. I'm also responsible for publishing nonsense. Medicine is not science. Medicine is always lagging behind science, and medicine is conservative. So it's only a year ago that we published, a community of experts published, that the relevant cutoff, the clinically actionable cutoff, is 10%, but we already don't believe that. So you can go deeper, you can go below 10, but you need a very knowledgeable lab. So you have to push, you have to request that the labs are certified, the labs know their job.
2 minutes, sorry. Yeah.
No, you're not fair. Nicole spoke twice than me. So you were a bad moderator, and I will not buy that. So
let me ask, we have a 45-minute break. I'd like to have time for Q&A. If we cut that down to 30 minutes for the break, because I'd like to give everybody the time. Yeah.
Okay. So, getting back to your question, what do we need? It's not what do we need to test, but what do we need and how can we move forward? By being less ambivalent, by very regularly updating recommendations, by ensuring broad coverage, it's not like that today, by deciding about the methodology, and finally, by collaborating. Very recently, the European Hematology Association set up what they call Precision Hematology Scientific Working Group. And precision hematology means bringing the lab and the clinical practice together, performing the right tests. And in that group, I've been assigned the task of supervising that recommendations will be updated twice annually. As Nicole told you, we learn about new drugs every day. And new drugs match particular genomic profiles. Unless we have very regularly updated recommendations, we will not move forward. This gentleman came to us at the age of 57 in 2009, typical CLL, early stage. However, he progressed in 2 years with anemia and a large spleen, so he had indications for treatment. We did all the things we should do. We found trisomy 12 by FISH, fine. Negative for TP53, mutated immunoglobulin genes. Back at the time, and as Nicole told you, even today, she said, you guys, if you don't have a TP53 and you're IG mutated, yeah, I will recommend FCR. He received FCR, but nothing happened. In fact, nasty thing happened, because after only 14 months, he progressed, and he needed a new treatment. So we did what we should do, as he's ultra high risk also. FISH, trisomy 12, and now you know the tricks. We did NGS for TP53, nothing. Nothing. So, move on, please. Can you move forward? So, one back. There is a clear message. Not all aggressive cases can be explained by a TP53 aberration. And an obvious question, what else can it be? The answer, move forward please. The answer in this case proved to be a mutation in a different gene. We call it Notch1. So the patient was negative for TP53, failed FCR, in spite of appearing to have a very favorable profile, but then he had a Notch1 mutation. So let's go to the why statements.
You should get this approved everywhere.
Let's go to the why statements.
I will vow.
And the why statements are horribly ambivalent and confusing. Additional genomic aberrations, such as mutation in Notch1, can have pathogenic as well as prognostic significance. However, more data from prospective trials are needed, blah, 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 blah. Happy with that. This is conservative, very prudent, very nice. Are you happy? Because I'm not. And there is also a very clear message here, if my slide, okay, moves. Again, we have to be less ambivalent. We have to regularly reappraise. We have to collaborate, but very importantly, here, why did we miss a very important point? Do you know why the WISE recommendations are so ambivalent? Because although despite having the evidence that we need about Notch1, this evidence was obtained from unplanned analysis. So when the study was designed and patients were stratified, they hadn't thought of including this biomarker in the workup. Sorry, but this is complete nonsense. So we have to be very comprehensive when planning studies. Venetoclax, ibrutinib, whatever, they are so horribly expensive, acalabrutinib, whatever, they are so horribly expensive that it's such a waste of, it's stupid. Sorry for saying it so bluntly, but it's stupid to not perform a comprehensive assessment of biomarkers particularly in the context of a clinical trial, because if you make that mistake, these are things that will happen, like this gentleman receiving FCR, whereas he could have received different things. Last case. She was 67 in 1995. Very nice. Early stage. And then David Osier, my very close friend, and a pioneer in genetic analysis of CLL, he performed karyotypic analysis, and he came up with a horribly complex karyotype. Fish revealed deletion of chromosome 17p, and TP53 analysis revealed a pathogenic mutation. Is it bad? Okay. Can you move? Yeah. Now, you spoke about karyotypes, and again, let's see what they say here. They say last year that it may be useful prior to therapy if established methodologies are available. Again, a nonsense, because we know that established methodologies are indeed available. So it's very complex, it's very bad. And they also say, we also say, that if the karyotype is truly very complex, with more than 5 aberrations, he or she had 8, it's really nasty. This is what we published 3 months ago. So I will ask you to vote. Who believe that she experienced disease progression, received treatment, and responded? Hands up, please. She had progression of the disease, clinical progression. She received treatment, and she responded. Hands up.
Which treatment? Which treatment?
Treatment. Treatment. Please remember, the diagnosis was 1995. So, I say one hand here, 2, 3. Okay. Who vote for number 2? She experienced disease progression, received treatment, and proved refractory. Okay. And who cannot make a guess? So I think we have a tie between numbers 2 and 3. Okay. She is 92. I spoke with David. She is doing great. In fact, she was in a Greek island this summer. And here is where I strongly disagree with the statement by Nicole.
No. I said prior to any therapy at the least.
Momento prego, signora.
No,
We don't have to test any patient at diagnosis. Okay. Because if you test patients at diagnosis before they have indications for treatment, then you may end up with things like that. Because having this information, that she has a horribly complex karyotype, and that she has deletion of 17p and the TP53 mutation, would be a huge cause of concern and worry for that lady who never required treatment. Nicole made a very nice distinction earlier between biomarkers that are prognostic and biomarkers that are predictive. If a patient comes to me with flu and asks me, what will happen? And I will say, oh, nothing, you'll get well. I'll be right in 99.9% of the time. But the unfortunate patient who dies, I will prove a huge liar. So prognostication is something that is useful for us, physicians, to get an idea about what to expect in every setting. But it's utterly pointless unless it helps in taking a decision about how to manage a patient. So we care about biomarkers, but only at the time that a patient requires treatment. I'm sure that Brian will jump up in the discussion, and I've been one of the advocates of knowing what to test and when and why, and I will disclose that I am doing one test at diagnosis, but I will tell you one during the discussion. So please do not forget that we are dealing with diseases rather than biomarkers. If I run NGS analysis for various genes in the audience of this room, more than 60% of us will carry a variant that may be pathogenic in one gene. Does this mean that we will develop a disease? Far from it. I will close with US data. It was presented at ASH. 31% of those who need it get FISH analysis, 11% TP53 mutation screening, 11% analysis for immunoglobulin genes. So Eric is very firm that we must and will change this. And we do it with various ways, but particularly through the establishment of two networks. One is the TP53, the other is the IG network. And what we do through these networks, we run 2 certification rounds per year. So labs are invited to participate. We send them a reference material, and they send back results. We assess how they performed, and we give them a report. And they're invited to be recertified, so every certification is for up to 2 years. We recently established a collaboration with the UK NECAS, so it will be very systematic, and we are very, very happy that now we have, this was from last week, now it will be 170 certified centers in more than 38 countries. So the next time you go, your physician tells you, you need to be tested for that. Please ask your physician, is the lab certified by Eric or not? That's all I had to share with you. And these are the people I have to thank. And I will be really very happy to hear what you have to ask me, Brian, and any of you.